Let us look at how do we approach a patient presenting with preterm labor. A patient comes to your OPD or your triage area complaining of pain in abdomen and altered vaginal discharge, and you are unable to make out whether it's a prom, whether she is having urinary problems, or whether it's something else. And then of course, how are we going to place the various kinds of screening techniques that we have, or the diagnostic techniques like the free fibronectin levels or the PAMG in this entire algorithm. So let's see that a woman has come to you at less than 34 weeks of gestation with symptoms of preterm labor. So what's very important is, after you have done her general assessment, looked at her per abdominal examination to identify the uterine activity and definitely rule out a very highly tonically contracted uterus, confirm the fetal heart activity, and then perform a per speculum examination. Always avoid doing an immediate per vaginal examination. Do a per speculum examination so that you can avoid unnecessarily stimulating the cervix and releasing her inherent fibronectin levels to inoculating her with an infection. And secondly, this also gives you an opportunity to do various tests. So if there is an obvious prom which is seen, you are seeing actual liquor inside the speculum, then naturally your treatment protocol changes. But if you see that there are maybe evidences of infections, or maybe there is a discharge which you are not sure whether it is a prom or whether it is vaginitis, and then you decide to wonder whether this patient is going to go in labor, should I now perform the fetal fibronectin test or the PAMG1 test. So always do a speculum examination, direct the speculum to the posterior fornix of the vagina, and then looked at the pooled secretions there. If the patient has already started dilating, you may be able to even see the bulging membranes or the open cervical os. So then be gentle, just take the collections from the posterior fornix onto a swab. You can also use this opportunity at the same time to take a swab for vaginal assessment, vaginal infection assessment for culture and sensitivity, and you can also use the same swab to do the nitrazine test, which can tell you whether there is prom. You can also take the secretions and perform the Fern test if you have no access to the PAMG1 or the fetal fibronectin test. As we know, PAMG1 is the placental alpha microglobulin 1 test, which is performed to predict spontaneous preterm birth. Now, if the membranes are intact and if you decide to do a vaginal examination, please do not probe the cervical canal with your fingers. Gently do a transcervical vaginal assessment, which will tell you about the vaginal effacement, and that is the only thing that you need to know. Because again, poking your fingers into the cervical canal can unnecessarily stimulate the myometrium and cause ascending infections. So now segregate your patient as a patient who is cervix less than 3 centimeters dilated, cervix more than or equal to 3 centimeters dilated, and cervix which is long and closed. Now, if you have a patient who has a cervix which is long and closed, the contractions have subsided, there is no clinical evidence of preterm labor, just reassure the mother, and there is no need of doing the PAMG1 or the fetal fibronectin test. You can just give her tocolysis, reassure her, and then explain to her about preterm labors, and she may be discharged home after you have finished giving her antenatal steroids and the tocolytics that you have planned to give her. If the cervix is less than 3 centimeters dilated, look for ongoing uterine activity. It's always a good practice to document with a tocoprobe on a CTG or an NST TRES, and look for a clinical suspicion of preterm labor. In such a situation, send either the fetal fibronectin swab or the PAMG1 test. Of course, this depends on the accessibility of your facility as well as the patient. If the cervix is more than or equal to 3 centimeters dilated, there is a regular uterine activity and the diagnosis is now a preterm labor, then we have to now treat preterm labor. While we are treating preterm labor, it's important that you take records of using one, antenatal steroids, even if the baby is going to deliver in the next 1 hour. Giving at least a single dose of the antenatal steroid has improved the outcomes of these premature babies phenomenally. So, if you have time, always give her antenatal steroids. You can also consider giving a loading dose of magnesium sulfate, which can help in improving the neuroprotection of the baby. There is of course a concern of postpartum hemorrhage after the delivery, but this is a theoretical concern and it has not been proved beyond doubt that magnesium sulfate related relaxation of the myometrium would give rise to postpartum hemorrhage. Of course, when the cervix is more than 3 centimeters dilated, there is no reason why you should do the PAMG or the fetal fibrinorectin test. Now, when you have sent the FFN test in the patient who is going into imminent labor, if the test comes positive, treat for preterm labor by using tocolytics, corticosteroids and antibiotics per your hospital protocol. It's always a good practice to use a combination of an anaerobic such as metronidazole or secnidazole and azithromycin, which can be given orally and which will help taking care of a broad spectrum kind of a spectrum, or you can consider giving 1 gram of any of the cephalosporins or maybe 2 grams. Do not give unnecessary extended antimicrobials because they are known to disturb the probiotic milieu in the vagina and inside the intestine. Consider transfer of this patient to an appropriate level of care. If you are not able to cater to this baby, rather than delivering the patient with you and then putting the baby into an ambulance and sending to a NICU, it would be better that there is a in utero transfer for better perinatal outcomes. If the PAMG or the FFN test comes negative, reassure the mother. Follow up again with an endovaginal ultrasound of the cervix if available, so that you can identify whether the internal cervical os is closed or opening. Treat for bacterial vaginosis if it's present, and we all know that many times BV can be asymptomatic, and the treatment is simple by giving clindamycin and by giving the nystatin pessaries, or you can consider giving her oral azithromycin and secnidazole, and consider to repeat the test in 7 to 14 days if symptomatic and if you find it necessary. So this is a general algorithm which I have told you about how to approach a patient who has presented with preterm labor symptoms. We have already said in our other videos about the details of how these tocolytics can be used and the details of the antenatal steroids.